Welcome, everybody. I'm Siva Deal. I'm the Public Policy and Advocacy Director for NAMI, Wisconsin, and I'm a proud member of the Mental Health Action Partnership. So we're very pleased to host this learning session today on catch safety plans. MHAP is a statewide mental health coalition concerned with ongoing mental health system improvement throughout the state, across the lifespan, and across the continuum of care. So kind of big tent, and many of you belong to various parts of this big tent. We're very pleased to welcome our presenters who are going to talk about an evidence-based practice that was developed in Ashland and Bayfield Counties in northern Wisconsin, right up by Lake Superior, with the idea that it could perhaps be replicated in other places. Although the presenters are going to talk to us about some of the groundwork that would need to be laid in order for that to happen. So we're going to hear from our presenters and then take a few clarifying questions, and then we'll break into small groups to discuss what we've learned and what questions you have about catch plans, and then how this practice might fill a need in your community. So I'll start by introducing this topic. Northern Wisconsin, like many sparsely populated regions, faces issues of low access and connectivity to care. So catch is an innovative community project that allows participants to create mental health advanced directives that are stored in HIPAA-compliant community database and can be used by first responders in a time of crisis. So this really fills a need that most communities face. This presentation is going to share how catch came together, how it works, and key elements that can help other communities develop a similar program. I'm very pleased to introduce our presenters. Wendy Kloiber is the Resilience Alignment Beekeepers Director. She came to this role after working in the school district at Ashland as the Project Aware coordinator, and the safety plans kind of link to Project Aware because as director, she created multidisciplinary teams to advance mental health and school safety, and did resource mapping and needs and gaps assessments, partner development, and innovative approaches to programming. She's a graduate of the University of Wisconsin Law School and the University of Wisconsin's La Follette Institute. As director of the Beekeepers, Wendy has overseen the creation of Wisconsin's first accountable community for health and the community development of a shared safety plan that first responders can access during crisis. And that's what she's going to talk to them about today. And her colleague, Amy Syverson, serves as a consultant with the Resilience Alignment Beekeepers and as the grants manager for NorthLakes Community Clinic. She's worked in direct collaboration with Catch Partners and Wisconsin Statewide Health Information Network, or WISHN, to create the first of its kind software to facilitate creation and sharing of participant-centered safety plans for use in wellness and also in crisis settings. Amy has decades of experience working with a wide range of community and state partners to implement changes and improve behavioral and community health. So I will ask our presenters to take it away. Wendy and Amy.
Thank you so much, Sita. We are really honored to be here and to get to speak with you. And before we get started, I just want to call out that our longtime academic partner, 9 years now, Dr. Michelle Broaddus, is here with us today. So, Michelle, we are hoping that you will chime in as soon as we miss anything. We want to give you sort of an introduction to how this came to be. And Amy, if you'll take us to the next slide. We want to just start off at the very beginning from saying this was an 8-year grant through the Medical College of Wisconsin's Advancing a Healthier Wisconsin Endowment, and we needed every minute of those 8 years and more. So if there's anybody that is listening right now that is from the funder side, we're here to talk about the real advantages of longer term funding when it comes to making systems change. So what did we do with this grant? We got this grant. We had a very open-ended mission to improve behavioral health outcomes in Ashland and Bayfield counties. And at the table at the beginning, we had county mental or health services. So services or agencies that were providing CSS and CSP, and were connected with many people in the community through that lens. We had law enforcement agencies, we had schools, we had our critical access hospital that is now Tamarack. We had NorthLakes Community Clinic, and we are part of NorthLakes Community Clinic, and NorthLakes got the grant. But for purposes of this project, NorthLakes really made a decision to sort of carve us out as a separate little bubble so that we could also bring the people from NorthLakes who would appropriately be making decisions for NorthLakes on behalf of the agency, and to really let us focus on being that backbone organization. And then really critically, we had people with lived experience. And because we are such a small community and things get really intimate here, at the table, we had a person who had been through the emergency detention process with a law enforcement officer who had been there and had been part of that emergency detention, and the behavioral health director of the hospital where that emergency detention was held. So we really sort of had everyone in the cycle of that process, which was really powerful when it came time to talk about what would make a difference. Why crisis? So as we started doing interviews and really doing some surveying to see where the possibilities, where the levers were that we could make change, we found that crisis was the place where everyone hated what was happening. No one was pleased with the way that that went. And yet nobody owned it fully. Everybody had a piece of the elephant there. So when we were able to bring that group together to say, here's everyone that touches crisis, what would you like to do there? People really surfaced that by the time that 911 call has been placed for a person who is having a mental health need for some intervention, by the time that call gets made, usually, not always, but usually, that person had already relationships with somebody who was around that table. Maybe they had a counselor, maybe they had a caseworker at the county, but it was a rare experience that somebody was coming into that system from scratch. So what that group said is, we know a lot of stuff, and that person knows a lot of stuff that could really be useful in that crisis moment. But because of HIPAA, there's no way to bring that information and those people and those resources and that understanding into that moment. How can we do that? So we spent a long time and had really excellent assistance. So for about a year and a half, Karen Timberlake, who at that point was working with Michael Best Solutions, would come up and spend 4 hours a month. We'd have these incredibly long meetings working through how it was that we would move that information that existed in the community and with the person into that moment of crisis. So the group wrote plans together. They wrote an ROI, and maybe we can go to the next slide and start talking about those. And they wrote training and a whole lot of process. So we ended up developing a software solution that could hold these plans. So in addition to, like, it's not that the group sat down and wrote a plan. The group really sat down and created a platform, a way to legally and ethically share information and work together as teams in a way that didn't exist before we had that ROI, where we could get informed consent from participants to share that information and do communicating that was specific around those incidents of crisis. And then as we developed it, we learned, sorry, Amy, I'm still on the
jumping ahead.
And the first slide, we assumed as we created this that the main place where these plans would be used was in the field. We assumed that an emergency detention would happen. The flag in the CODI system, that is our law enforcement's equivalent of an EHR, would pop up, and that they would be in use all the time. And what years of experience now has taught us is that they are equally as much a tool for prevention and that a key element of that prevention is participants knowing that their wishes are in that system and available to first responders. That's been a really powerful thing, whether or not it is actually used in the field to help reduce that number of EDs. And then it's also a platform for collaboration around continuous improvement with the crisis process and around other kinds of things like CIT training that fit really well with this idea of having a shared community language and community response in mental health. So this is, like, I hate to even say this because I'm sure that everyone on this Zoom knows this already, but reducing emergency detentions. If you're working with someone who doesn't need emergency detention, but who could benefit from calling in a friend or a support person, who could benefit from some time working on a de-escalation activity that they've already identified and put in that plan, if we can pull in the right kind of support at the right moment, put more tools in the toolbox for first responders, our working theory at the beginning, and it is beginning to bear out in the evidence now, is that we could reduce emergency detentions by creating more ways to handle them. And that's just better for everybody. And we could go through this list, but I'm sure everybody here has an understanding of emergency detentions as both expensive in the money sense and expensive in the sense of, particularly for us in rural areas, they move people frequently out of their home community. There's a lot of travel or lost time you're no longer in your space with your people. It's just a really hard situation that may and does and is useful to keep people safe, but nobody really feels like it's ideal. And when you have an option to handle that incident in home and feel safe that that person is going to get what they need through pulling in the resources and doing the activities that they've identified, it's just really good for everyone.
So, when we started this project, one of the questions we didn't ask was, what does the research say about safety plans? A lot of our partners in the counties were already using safety plans and could feel the value of those. But a little ways into the project, we realized, wow, what is the benefit of safety plans? What else might be going on there? And so, thankfully, we had our partner at the Medical College of Wisconsin, Dr. Broadus, to help us find what research had already been done. And it turns out there was a lot of research out there that had been done around safety plans. Not all of it identical to what we were doing. There were different components and done in different ways, but we did see some things that were elements that made safety plans effective. And in those systemic reviews of the safety plans, we learned that making a safety plan, when it's done with some important elements, can reduce suicidality, suicide-related outcomes, has better outcomes for hospitalizations and engagement with treatment, and that the components of those safety plans that was important included, making sure that those safety plans weren't just boxes that were checked off, but they actually had information infused in the plan that the participant or the patient got to put into the plan that was important to them, and that was done in joint facilitation with a skilled facilitator who could help guide that person to find, kind of tease out those things that were really valuable to that person. And when they did that, that reduced rehospitalizations after crisis. So we were feeling pretty good because we had kind of hit upon those elements when our team kind of naturally went through creating this safety plan. We had some of those elements, and we did have those trained facilitators. I've got a link for anybody who's interested in looking at those surveys later, and we'll make sure you get a copy of these slides. So what is in our safety plan? Well, our group took a lot of time to look at the existing safety plans that were being used by our hospital, being used by our counties, being used by our clinics, and came up with our own. And the things that are in our safety plan are as important as the things that are not in our safety plan. So our safety plans have who you are, where I live, what I'm feeling what I'm feeling when I'm unsafe or need assistance, what that might look like, de-escalation strategies that work for me, support people to call. This was a really key element. Who are those natural systems of support that you can call? Other things that might be important to me that we've missed. And key, what would you like law enforcement to know? What are some of those really important factors as someone's approaching you for the first time? Those first responders, what's important? And then your signature. And that was really important to our folks with lived experience who said, I might not remember making this plan if I'm at a heightened state of crisis. And so sometimes seeing your signature and seeing your handwriting, so we have a way for that to be captured in our system. What's not in the plan, and there's a little asterisk here, unless someone would like to share it, is your diagnosis, your treatment plan, your prescriptions, your history with law enforcement, and anything that a participant doesn't want to share. So if there's a question on our safety plan that you're not comfortable answering, there's no obligation to fill out the whole safety plan. This is your plan. You put in it what you want. And the extra key piece of that goes with the safety plan, it's never separated from the safety plan when we print it out, is that release of information that says the information will be shared with all our catch partners, but only used in a time of crisis to ensure safety and well-being with me and my care team. And that idea of the care team is something that changes, right? So it's the people that are there during that time of crisis to care for you. Once that period is over, there is no more care team, right? So you may have a facilitator that helped you make a plan, but only people who are helping care for you in that time of crisis will be the ones looking at your plan. That your plan can be revoked at any time. So you're not stuck with this plan forever. Our plans expire after 1 year because we know people's needs and their lives change. And we didn't want people to be saddled with information that was out of date or no longer served them. But the plans cannot be revoked during that time of crisis. So we wanted to make sure that that information could still be used by first responders if someone was unable to make the choices they needed to make during that time of crisis. And then the ROI stays linked to the catch plan, and that people understand that they're publishing that information to the Wish and Catch portal, which is an electronic health records system. So they know where that information is and how to remove it. They can either go to their facilitator or they can go to Wishin. So how do we store plans? Well, that was a big question. We started off with law enforcement officers saying, can't we just keep a binder in the back of our car that has copies of all the safety plans? And, that had everyone pulling their hair out, from our county folks to especially our folks working in the hospitals and healthcare. So we were able to get in contact with Wishin. So Wishin was the designated health records exchange organization that came into being during the Affordable Care Act. They were a statewide nonprofit, and they had never done anything like this before, but they did know how to handle HIPAA protected patient data. And they were able to create for us something that law enforcement agencies in Ashland and Bayfield County could use and access during a time of crisis. We did find a little hitch, though, is that sometimes en route to a crisis, it was difficult for law enforcement officers to know and look that plan up when they're kind of en route. So our law enforcement agencies put tags, little flags in the system to say, hey, this person has a plan, and if you're en route, you may need to look that up. So this is our Wish and Catch portal. It's not perfect, but it has worked for us to be able to store those plans. So go ahead, Wendy.
Sorry. So how are our partners using catch plans? There turned out to be a number of ways. Some of our partners have integrated catch plans as their in-house plan, so that when they are filling out a safety plan with a participant, which they would do in any case, that plan is the catch plan. And then at the end of filling that out, there is an option for that person to upload it or not upload it as they choose. It's also been really crucial in a way that we didn't necessarily envision in the beginning, as a tool for the participant to take home and use exactly how they want with their support people in ways that we will never know about unless we get lucky and are able to ask someone. But as a personal tool for people to use and activate their own communities of support in times when they need to do that. Again, it's frequently for a number of organizations, it's the same plan that they're using already, so that there's a lot of integration there. And really importantly, it created a lot of shared language along with being a shared tool for individuals and agencies. So one of the unintended and excellent consequences of this project that you'll hear more about in a little bit is that it really pulled together some very disparate agencies. It's not often that you get to have a table where law enforcement and therapists and county service providers and people with lived experience are having in-depth discussions about what would make things better. But that has been a really powerful side effect of plans. And then fringe benefits of doing work together. It's been an incubator for new collaborative projects to emerge. We talked a little bit about CIT training. Another piece of training that we have done is the CCRS, Columbia Suicide Severity Rating Scale. We did a workshop where we realized that if we were all using that language, kind of everybody in the room was a number on there for something else. That if you were working with somebody who came out as a 3, here was who you would contact to get them 3-level services. If you came out with somebody who connected as a 1, here's who you would contact to get them 1-level services, and then really kind of mapped out how you would connect people to appropriate services using that language. So another way to really build common words, common tools that help everyone sort of knit together more closely to provide better services. Learning about each other and building trust has been a huge, huge consequence that has kind of rippled out into projects that we hear about later and are overjoyed to find out about, but that we didn't intend in any way to have happen. It's just been a really fantastic side effect. And all through the project, from the beginning when we were able to meet in person, and then in COVID times when we were on Zoom, and we've actually stayed on Zoom because it's been convenient for the group. It's been an informal space for problem solving. Almost every meeting, somebody would grab somebody else and say, "Hey, can I have you for 5 minutes at the end? Can we just touch base about this thing?" And when we left physical space and went into Zoom space, we kept that. It's the last item on our agenda in every meeting. Does anybody need a breakout space to grab someone else? And it's really rare that nobody does. So there's been a place to say, "Hey, can I just get you?" That has been really helpful, I think, at a more problem-solving level for individual cases and problems that may be going on. Just a quick look at our founding partners so you can sort of see the diversity of people and agencies that we had at the table. Having that diversity was really key to be able to create something that would be of assistance throughout that whole list, where what we really wanted to achieve was that everybody on that list felt like engaging with this project would create better outcomes for them and for the people that they served.
So here we just want to share very briefly a couple of stories from our partners.
Not
It's
playing.
frustrating sometimes when you deal with a person that you know receives mental health services somewhere or medical services, but because of HIPAA and other that hospitals have to follow. They're not able to communicate with us about a patient because they can't admit that that's a patient of theirs. And I had a scenario one time where someone called, they were very concerned about a young man that they were working with who was doing things that were pretty upsetting to them, but nothing to the bar that was criminal. It was definitely a mental health thing. And that coworker knew that he was in mental health services and that he had an appointment coming up. And they wanted a message sent to his mental health provider that he was struggling and exhibiting some of these behaviors because they thought he needed medication adjustment. So I literally called every single place in the area that you could possibly go for mental health treatment and was never able to confirm if whoever I talked to actually was the provider or not. So I gave the information to every single one, hoping that it got to the right person, but it just shows a lack of being able to communicate that is not helping the participants. So routinely.
And here's from some of our hospital partners at Tamarack.
So at any time in our life, we could be struggling. And in that struggle, sometimes as clinicians, what we're trying to do is first help us get over our denial. And many times, either we think, oh, I'll just power through this, I'll be okay. And then I'm realizing that power's through, so I said, I got to get some help. And then that first part of all work with clients is helping them come to terms, helping them accept this isn't going well. I'm doing the best I can, but it's not working. So when you begin to work through that denial, then you begin to accept the conditions of what life is offering at this moment. And from that ground level, you can begin to rebuild. So what does that look like? What are my elements that I need to start rebuilding my life? Rebuilding or coming back to my life. Managing and looking at times of crisis. Managing and looking at times of crisis is one of those elements of rebuilding life. It would be very appropriate for some individuals to say, I may or I have fallen apart and had law enforcement come on out and do a witness check. I can have a voice in that. I can control that. That's really empowering for the patient if they really understand what that means. I can have a say in how law enforcement is going to approach me and what will happen when they come out to a witness check for me. It's a real empowering part of a person's recovery. It's taking back their life.
And then this is from our partner, Deputy Runas from Bayfield County.
Several years ago, when law enforcement or I responded to calls of service where somebody's in crisis, it was a very difficult situation to handle, where that we had to try to give somebody care, try to find a hospital for them to go to, try to have the same understanding with maybe hospital staff or counselors for us all to be on the same page. Because of the implementation of the catch plan, it's allowed us to have better cohesive meetings, learn about each other's organizations so that we can develop a mechanism that provides better care, more personal to people in our communities. So anybody that's
So we have many more of these and more than we have time to share, but there's a link here for anyone who's interested in hearing from more of our partners in Ashland and Bayfield counties.
So
Oops, there we go.
Thank you, Amy. So what we weren't able to do when we did this filming was to film a participant, but we felt that input was so important that I am literally just going to read this out to you. It comes from a catch participant who was willing to share impressions about the project with us. I struggle voicing out my problems, so having to sit down and voice out, this is what I can go through, this is what I probably will go through, and how to prevent it was a little challenging for me. From, I don't know, 12 years of age, I always like to bottle things up inside. I never wanted to talk about it. I never wanted to express what's going on. I just wanted to contain it. Yeah. So it was a little challenging. In the end, it was actually more of a relief to be able to have something out on paper that this is what I go through. This is what to expect. It means I don't have to rely on just myself anymore. I can rely on other people too. So, beating the odds, we are in year 9 of an 8-year grant. We found additional funding to keep us going. We have a year and a half left of funding to improve and continue the work that we're doing. And after this round of funding, the future of catch is uncertain, and it's uncertain in a couple of different ways. One is that grant funding, as everyone I'm sure here is deeply and painfully aware, is an awfully hard way to keep a project going. And also, we're experiencing at the moment something that was a huge dream for us and is a dream that has sort of come in like a tornado, which is that Senator Jesse James, who many of you may know, he is a working police officer, also currently serving in the Wisconsin legislature as a senator, has a real interest in this topic and came to a meeting of our work group to ask questions and listen. And then when he founded the study committee on emergency detentions and civil commitment of minors last fall, he asked us to come and present. And out of that presentation and more conversations with Ledge Council has come a bill that would scale catch at the state level, which is thrilling and is also occasionally discombobulating, because suddenly a whole lot of people outside our small catchment area in Ashland and Bayfield counties need a lot of information to make good decisions. And we want to be as responsive as we possibly can and share what we know. And people have fascinating questions. Some of them are the same ones that our group had when we got started. Some of them are different, but we have experience that we can bring to bear on answering them. So it's part of what we're thinking about right now as we go through this next piece about what would it take to make this available to more people in the state of Wisconsin. So I'm sorry, is there a question? Can you give us the bill number? Yes, we will absolutely do that, and probably at the end. So 3 things that we think are really crucial to making this work at the state level. Thanks, Amy.
Sorry.
No problem. A home at a state level agency, and it looks like right now the way the bill is written, that would be DHS. Facilitation for pilot communities and a statewide software solution. And we'll go through and talk about these. And then what do we have that we can share? What are the tools that we have to make it so that people who want to create this kind of project don't have to start from scratch? A legal framework. We have like all kinds of the building blocks of this project that we can hand over and say, adapt these how it works best for you. So facilitation is really key, and we've gone through some worries. Oh, Michelle, thank you. About whether or not that would end up built into the bill and if we had made a good enough case for it. But we really feel strongly that if you build a database without facilitation, they will not necessarily come. So in that sort of year 1 space, the process that we've laid out there is very similar to the process that we went through, which is really crisis mapping. And as people in this room know well, no 2 counties crisis process looks exactly the same. There are idiosyncrasies, there are differences, there are strengths and weaknesses that are unique to each catchment area. So one of the key pieces as we got started was to really do in-depth interviews with each of the partners that said, what is the crisis process like for you? What is working well? What are those pain points? And then to share that all out to the whole group and let people explain, because frequently somebody's pain point was somebody else's, I have to do this. I'm mandated to do this by law. I hate doing this, but I have to do it. And it really created a lot of understanding among those partners who may previously have experienced irritation or upset about the way different partners were handling different pieces of the process, to sort of understand what was motivating those actions. And it was really profound. And we are hoping that other communities that take this on get to go through that same kind of process mapping. And then when you have done that, taken a good look at your process, figured out where a safety plan would fit into that, then there is a piece of that facilitation that is about mapping workflows, making sure everyone has training, making sure there's a common understanding among that very disparate group of folks about how plans will be shared and used so that everybody's on the same page, and also including in that some table topping about what happens if something goes wrong, what will we do if there is various kinds of issues that people brought up, can we figure some of that out in advance? Can we write an MOU that's reflective of that?
So software. One of the challenges that we had is that we started this project on a shoestring budget when it came to developing software, at least from a software perspective. And the solution that Wishin developed to us is really like a little add-on. So they've got their statewide electronic health records where they're able to share information with all their healthcare partners. And that was important to us because we thought at the time that maybe we could scale this and bring this to our emergency rooms, to our primary care physicians, to have everyone have access to creating and seeing those plans. But we didn't have the things we needed in their primary system. So we built an add-on. And our current system is a proof of concept, but it won't scale. So we couldn't take what we've got from Wishin, and they couldn't say use that in a community the size of Wausau or somewhere bigger. And the thing that we found really valuable is having those flags in law enforcement software. And right now, our law enforcement agencies are hand entering those flags and any critical information from the plans that needs to be added. So we asked Wishin, we said, what would it take to scale this to a solution? Because the study committee was asking us, how could we do this at a statewide level? And they came up with a possible solution. If we were to do this and move this into that larger system, they would need to make some adjustments, and that would cost about $225,000, which on a statewide level is not that much, but on a local level for two small rural counties was far and above our budget. And the proposal includes the possibility of interoperability. Now, as everyone knows, that's a real sticky point, especially when you're talking a lot of different counties using different law enforcement software or schools using different types of software. So this would make it really easy if we could figure out that interoperability piece. More to come, we hope, right? And the numbers, right? We really wanted to share as we kind of wrap up talking about this project that when we started talking about catch plans, we were asked to come up with what number do you want to move when it comes to your project? And we were like, how about emergency detentions? That's what we're trying to work on. I don't know if anything that we do as a work group could really affect those numbers, but it's the number we chose. And we were worried, like, what if something big happens? Like, I don't know, a pandemic maybe, right? Like that might affect how our community's mental health and the number of emergency detentions that happen. And that did happen. But we found a really interesting thing that we didn't quite expect. Is that our emergency detentions in Ashland and Bayfield counties have gone down significantly. So you'll see Ashland County in 2020, which was the year prior to us implementing our catch plan project. We'd been working together, but we had to kind of wait until 2021 to really get that implemented. We had 65 emergency detentions. Bayfield County had 29. By 2023, that number in Ashland County had gone down to 34 and Bayfield County down to 17. These are the only numbers I have for Bayfield County, but we have more numbers from our City of Ashland Police Department, and they're the ones who do the bulk of our emergency detentions in Ashland and Bayfield counties. So you can really see that going back as far as 2014, over the last 10 years, we're really at the lowest point we've been in a decade for emergency detentions. And that hasn't really been mirrored around the state. So we feel like we're a bit of an anomaly, but that's a place where we could really use some more research to tell this story well. And we don't have the capacity to do that. So we're looking for partners and hoping that we're able to dig a little bit deeper there to have these numbers tell the full story. The thing that's really interesting about these numbers is that these numbers are not coming because law enforcement are using these plans all the time to divert those emergency detentions. And when we talk to our chief of police in Ashland, he says, you know, we're not using a lot of these plans. I can only imagine, I don't know what else would be accounting for this drop in numbers other than the fact that people are making plans and that we're approaching things a little bit differently. So we're hearing that from our law enforcement partners, that change in how they're thinking about mental health and our participants feeling supported and having a way to kind of maybe do some diversion before they get to the point of having law enforcement involved is what's driving these numbers to come down. But like I said, these are just speculations on our part, but we're really excited because fewer emergency detentions is probably a good thing for everyone.
I saw a question asking if we had cost saving numbers. We wish we did. We're actively looking for partners to help us do that calculation. But it feels pretty intuitive to particularly to law enforcement that that's a real phenomenon that cost savings are being experienced.
And we did actually have numbers when we were first starting the project before we had started the catch plan project and we were just doing that baseline data collection. There was somebody within one of the counties who was able to do that. And we were looking at about $200,000 a year for our small counties, which is a significant part of those budgets. We don't know what that is now because we just don't have the capacity within our small county agencies to kind of do that kind of data analysis.
I saw a question from Sita asking about annual costs to operate catch. And Sita, I would love to be able to give you a number, but we have gone through different layers of software iterations. So our budget really fluctuates with whether or not we're able to and are paying for changes to software and upgrades as we go. So it's like a salary and a half and software.
But I'll also say that because this has been integrated at the county levels, there's not a lot of additional work that each of our partners is doing. It's really that bringing together and facilitating. And the overall software cost for our small counties is under $10,000 a year. So that really, it ranges between $6,500 and $10,000.
That's the ongoing cost for having access to the software, which yeah, that's definitely an ongoing cost. But we've had different costs in terms of build out and legal and development, and then round 2 of process improvement and round 3 of process improvement. So moving around, but like a person and a half, $10,000 for maintenance, and then software all over the place.
Diana. Hi.
Hello, nice to see you. And I've been, as one of the partners in the Advancing of Behavioral Health project, been following along, and it's been wonderful. One thing that we are looking at here in La Crosse is decriminalizing mental health and mental illness. And so I wondered in this, have you run into kind of more has the catch plan been able to help with emergency situations that involve whether it's misdemeanor or other kind of criminal, like criminal activity that is attributed to really mental illness. And yeah, can you speak to any experiences with that?
I think, and Wendy, feel free to jump in here, but I can't point to anything specifically, but what I can say is that, especially in Bayfield County, our officers there really talk about the shift in how they're thinking about mental health. Like, so being a part of this project and seeing plans and understanding this has kind of shifted their lens that they're viewing some of those mental health calls. The place that it gets really tricky is if people have co-occurring substance use disorders. And that is a place where, boy, wouldn't it be great to have some of those alternative response providers in the mix? Because I think sometimes law enforcement feels like their hands are a little bit tied when it comes to the criminal aspects. So I don't have a real clear answer for you there. But yeah.
Yeah, and we were even, just in a meeting yesterday talking about psychiatric advanced directives. So, kind of similar in the similar vein to a catch plan, having written down, while I'm not in psychosis, this is what what I find helpful. And so, yeah, I did the kind of a new document, a new area that I hadn't considered before. And so all really important work to be able to decriminalize mental health.
And we've just started to talk with folks about, everyone could at some point, you never know, like use a behavioral health advanced directive. So just going through that process, no matter who you are, could be valuable.
Amy, I wonder if you could sort of show the last slide with your contact information, and then maybe we can take it down for just a couple of minutes with clarifying questions. And that only clarify, like, what do you need to know about this program? And then we'll go into breakout groups and talk about the questions that you do have and your thoughts about applying this locally. But I just wanted everybody to see this contact information. It will be sent out to everybody at the end of this presentation, but let you all finish up and then we'll go do some clarifying questions and go into breakout groups.
Sita, there are a few questions in chat that I wanted to get to.
Okay.
And a really important one, is it okay if I?
Yeah, go ahead. So Amy, go ahead and take down your slide and then we can all talk amongst ourselves here.
So a really important question, what about the tribes? So in our region, we are adjacent to two tribes, the Red Cliff Band and the Bad River Band of the Lake Superior Chippewa. In our very beginning, like right before our first meeting in November of Amy helped me with the year, we had an incredibly heartbreaking incident here where a young man in middle school, a Bad River tribal member, was shot and killed by a police officer while that young man was experiencing a mental health incident. And at that time, we had huge plans to move forward with this project. And it was earth-shattering. It was just really, really a hard thing. And we sent out our email inviting people to our very first meeting right after this had happened. And we're incredibly fortunate that a Bad River elder responded to that message by saying, this is a good and useful project, and I hope it goes forward. So during that first 18-month period when we were meeting with Karen Timberlake, we had representatives from both Bad River and Red Cliff who were giving input during that time. But then when we moved to implement, both tribes said to us, this is not for us right now, and for differing reasons. One was really clear that the time commitment of that implementation and the amount of resource that founding partners were going to need to pour into that was not appropriate for them at that time, and that we should come back as we had a better and easier to use system that could be more easily implemented. And in the other case, there's a real concern about sharing information. And the whole idea of sharing information. People wanted it to be available to their members, but also it didn't feel appropriate to integrate into tribal health at that time. So I'm really grateful that that question got asked, because it's been an important part of our history. I'm wondering about the effect of 988 being available. Have emergency detentions in other counties remained stable, gone down, gone up? Wow, I would love to be able to answer that question. And I don't have any data whatsoever on 988 effects. So if anybody has any leads there, I would encourage you to jump in. This bill only deals with minors. Is there a bill for adults? So the pathway that this bill took through the study committee on emergency detention and civil commitment for minors meant that the bill coming out of the committee had a very strict set of parameters, but there is an intention at the state level to broaden the bill as it moves out of committee and into the broader legislative process. It's an artifact of its sort of birth home that it deals with youth, but there's very definitely an intention to broaden it out and make it useful for everyone. Any other questions we missed? I see Pete Christensen with a hand up.
Yeah, thank you for this. But I've got a question. Being that the mental health population that's in the prison system today, how could this be utilized within the prison system and researched and getting data that would be rather easy to do because of the confinement of the population? And it seems like what you're talking about, every prisoner should have this type of thing set up so that when they're in that crisis, those that are coming, to obviously diffuse or, de-escalate, have a real good understanding of who it is that they're dealing with from a mental health standpoint. Because I do know when you're in psychosis, good luck trying to get them to say, oh, hey, you know what? I'm in psychosis right now.
So I think that there is a path that would allow for that to happen. And we have taken a couple of runs at this with one of our counties in particular. And one of the things that came up as a struggle for us that we weren't able to ultimately mediate is that participants in catch plans have really all the power and all the cards. They get to choose whether to make a plan, they get to choose what goes in the plan, they get to choose how the plan is used, they get to remove the plan if they choose to. And one of the things that we weren't able to figure out was how to implement within the county jail system and still have that degree of participant ownership and freedom about how to use those plans and capacity to pull them. We just weren't able to figure out a way to sort of keep that core of participant ownership and bring it there. And I think that could be overcome, but we weren't able to do it in this particular instance. But I would be eager to try again. I think it's a hugely important point, and we would certainly love to see it go there.
Thanks so much. Great question, Pete. Does somebody else want to respond just with a clarifying question? These were great questions. We're going to go into breakout room for 15 minutes. And the questions in the breakout rooms are like, what other questions do you have for CAT? And then how might this fill a need in your community? And anything else you want to talk about in the breakout rooms. But we just wanted to get together in smaller groups and chew on this. Then we're going to come back and do some brief discussion, and then we'll close out. So Hannah, can you send us into breakout?